I'm Josie Butcher and I'm going to start talking about body image. This is an image that was created by one of our patient colleagues, um, and it looks from the research at how body image can be broken, looks at mending, and it looks at hope. Firstly, I'd like you to just take a few seconds to think about body image and what is body image. What is it for you? Is it just attractiveness? Is it about maleness or femaleness? Is it far more than this? Is it a sense of who we feel we are? What does it contain? And everyone will be different, so every one of us has a different view of what body image is. Colloquially, it is always thought as being whether we feel attractive or not. We have just completed some work in breast cancer research, working with women in focus groups and collaboration groups. And it's interesting to find out what we found from the research. What we do know is that we all have a sense of who we feel we are and what our body image should be like. And this is unique to each of us as an individual. As women, we called the collaborative work as an idealized femininity and sexuality. We also found that body image was about function and control. It was about trust. Do we trust our body? Does our body trust us? We found it was about our own self-confidence and self-worth, self-esteem. And we also recognised that having cancer made us feel disempowered. I want to introduce this model for working with body image to you. This was created by a psychologist called Phyllis Aldin, who worked at the Christie Hospital in the psycho-oncology department for many years. And the thing I like about this model, and she gave me the permission to use this for working with patients and also to work in an educational way, is that it doesn't give a hierarchical approach, i.e. it doesn't list one thing above another, but it is a range of difficulties that people have that actually can be concerned with body image. So we have that sense of self sitting there at the top of the circle, but there's also a sense of health and vitality. There's a sense of trust, which is what we found, a sense of sexuality, a sense of who we feel we are as a sexual person. It does look at appearance and attractiveness, but it also looks at things like control and function, which again is what we found in our work. And it looks at self-worth, which is self-image and self-esteem, again found in our work. We're going to be using this model through the process of this podcast. I just want to look at the problems around sex and sexuality for patients. Common themes from cancer research suggest that up to 80% of people would like to receive more information than they get. 75% say they wouldn't feel comfortable opening up discussions and were waiting for the health professionals to do that. And a Macmillan study that suggests 30% of cancer patients recall the discussion around sex, but rather about protection when taking chemotherapy. Our research, alongside other research, shows that it is difficult for patients to come to a service and to ask about the problems that they have. Patient worries include things like disempowerment, i.e., can I ask? Patients have been given life with their treatment, and so many patients feel that it is inappropriate to be asking for more. Can I ask about sexuality? Can I ask if my sexual function is not as good as it used to be? Can I ask if I'm not having any sexual function at all? Others will feel it's an invasion of privacy because it's difficult to ask about things that are very private. We might talk about these and have some banter with friends, but very few of us actually talk about the problems and difficulties that we are having. And then there's an anxiety about normality. If I want to talk about, is that seen as normal? Or is it that actually I'm abnormal anyway? So if I'm talking about what happened in the past, is that normal, what I've been doing? And then there's shame. What will that person whom I'm talking to think of me? What will happen? Will they feel that I am inappropriate asking for this sort of help? And then there's disloyalty to partner if I have one. This is a private thing that happens between me and my partner. And if I start talking about it, am I actually being disloyal to my partner? So I want to come back to working with this model so that we can understand what we're trying to achieve when we're working with someone with body image and what we need to explore. So what happens if you come to our service? How would we assess body image? Well, the service we offer uses an integrated assessment and therapy model, which is my adaptation of a gentleman called Weeks, who started talking about this approach in 2002. The patient is the top left-hand part of this diagram, and they will come with a medical component to who they are, and that medical component will contain their cancer journey, so their diagnosis, maybe biopsies, chemotherapy, surgery, radiotherapy, in what order, and how much has been repeated. It will have ongoing medications that people are taking, as well as other health issues that patient might have, such as diabetes. The number is limitless. It might be arthritis, it could be all sorts of things. And then there's the sense of who they feel they are as a person and the sense of sexual self or sexual identity. That's the psychological aspects that we're looking at in our service. A patient may have a partner, but doesn't have to have a partner, and doesn't have to have a partner to come to our service. That partner may be a same-sex partner or an opposite-sex partner or a non-binary partner. But that partner may well also have a medical component to who they are, and that might affect sexual functioning in the relationship. And they will also have a sense of who they feel they are as a sexual person. We want to know about the relationship or relationships that a person has, and we need to know what has been good in that relationship and what has been affected or changed in that relationship because of the treatments that people have had and their cancer journey. And also we want to know about the social context in which people live their lives. By social context, I mean the jobs that they do, the hobbies that they have, the friendship circles that they have, family and extended family groups, and what has been affected by their cancer journey, what has changed, what they can do and what they can't do, how they have had to adapt. This is what we call a biopsychosocial model, and when people come to the service, we're not being voyeuristic by asking these questions. What we're wanting to try and ascertain is what their body image issues are and how we can help them. I think it's important talking about sexuality to look at the definitions because they vary. And sexuality is really how we see ourselves and how we express ourselves in general life, not just in sexual experiences. It does include an array of social activities, an abundance of behaviours, a series of actions and society topics. It will include things like sexual intercourse, how we do this, what our sexual behaviour is, as well as the medical concerns and physiological changes, or even psychological aspects of sexual behaviour that can be affected. And it also involves sociologically all the cultural, political and legal issues, and as well as sort of the moral and ethical, theological and religious aspects. So if we stay with the medical to start with, and we'll think about our model that we've been looking at, if we look at the anatomy and physiology of the body that enables our body to work well, and certainly to work well in a sexual way, then we pick out function. Are the various organs complete? Is there a supporting blood system, nerve system, or hormone system? In all cancer treatments, anatomy changes occur. These can be obvious, but not always. So, for example, removal of a breast can give hormone change. Oral treatments can reduce saliva. The blood and nerve systems can be affected by surgery, chemotherapy and radiotherapy, and hormone systems are often affected by chemotherapy, pushing women into a menopause or depleting men of testosterone. So if we then look at the sense of self and look at who we are and how our body image is affected, so we're moving to the sense of sexual self now and the sense of self, how can we get an understanding of this? Well, the sense of self, which includes a sense of sexual self, is individual. So we do have some biological components to this. So if we have an intersex condition, then that's important because our biology is different anyway. As with gender identity disorders or gender dysphoria, and certainly in some situations sexual orientation is known to be biological. But what we do have to think about is where we get our learning about sex from. When we are born, we don't come out with preconceived ideas about what femininity or sexuality is about, what being a woman, what being a man is about. We gain it from our learning on the way, and this is well recognised now. So we're looking at various items, and we get our learning from four main areas. One is our culture, another is our religious, a third is a parental learning or significant adults, and then there are the life experiences that we have on the way. So what we'd be interested in and we will talk with people about is first of all the cultural aspects, and these may be wider, so we may have a wider cultural aspect. For example, I'm white British, but we live in a multicultural society, and so therefore people will not come from the same wider culture as I do. And then there's the street culture that we belong to, and that will be what we have learned on the way up through our schools, with our friendship groups, with the people that we've knocked around with, what we've learned from them about who we are, the sense of who we feel we are as a person, and the sense of who we feel we are as a sexual person. Religion can play a part for us, and we have to also remember that even if we are not religious ourselves, don't go to church or don't define us as ourselves as religious, then we can get intergenerational transmission of ideas, attitudes and beliefs that come from a religious background. So, for example, I may not be religious myself, but if my grandfather was a Methodist lay preacher, then those views, attitudes and expectations would come down to my parent and then they would come down to me. And we also talk about parents being very important in our learning and understanding of what is right and wrong and what our sense of self should be. But what we're really talking in this day and age is about significant adults. So it isn't only parents that we learn from, it's childcare providers such as grandparents, extended family members such as aunts and uncles. It's going to nursery, it's going to school, and it can be teachers that are significant adults for us. And then there are the life experiences we have, but we can't always just think, oh, well, it was a life trauma. It's what we learn from the media and society. And in our thematic content analysis from our research, then we found that these things were important in terms of giving us the roots to our learning. And it was about intergenerational strengths. It was about socio-cultural perspectives. It was about family attachments and nurture. It was about significant parental attitudes, beliefs and expectations. And it was about core values that we took along the way with us. So what I want to do now is just look at life experience a little bit more. Society, the media and political view is important. What are the images we are bombarded with? What age does that bombardment start? So what about TV adverts, films, newspapers, magazines, comics, Barbie for 3-year-olds, Action Man for boys, political views, and at the moment, of course, sex is seen as a lifestyle choice, and so medical treatments for sexual problems and difficulties are sometimes seen as rationed. Does it only pertain to women, or do we only objectify women, or do we also objectify men? And I think we all have to think about that. I want to talk a little bit about gender differences before we go on, and this is work done by Jan Otten from the Netherlands, and he came to talk about this in a presentation around prostate cancer in 2014, and we ran that conference in Manchester. In the Netherlands they talk about girls and boys, whereas in this country we would talk about women and men. But you also have to remember when we're talking about this in this way that we are all individuals and we shouldn't stereotype and apply everything to everybody. So we can't say, oh, well, you work like that because you're a man, or you work like that because you're a girl. There are, however, common traits that appear gender specific, and it's important to recognise these when we're treating people and when we're talking about body image, when we're looking at what people are bringing to us. So if we look at girls and women, communication development along the early years is that of networking with an interest in people, relationships, contact and sensuality. The concerns that women tend to have when they come after a cancer journey is, do I still have desire? Am I still attractive? So it tends to be about a networking approach. Boys and men, however, their communication development in early years and beyond tends to be about things. They will build things, and they're function oriented. So what they are wanting treatment solution focus with interest in genitals, orgasm and penetration. Does it work properly? So they will come along and be more worried about the function rather than networking and communication. There is some monkey toy research that's been taken ahead in Texas, and by that I mean monkeys working with toys, and it supports the understanding, and it suggests that this difference for boys and girls may be related to a physiological basis. And Isabel White's work, who worked at the Royal Marsden for many years, on her work on post-cancer treatment once, also reflects this approach. So if we look at this, it may be that when you go to see someone, there will be parts of this that are more important to you than other parts. And we've talked about appearance and attractiveness, and we talked about the difference between that and control and function. Both of those have touched on self-worth and the sense of who we feel we are as people. So how do we work with people? Well, a programme of care always starts with psychoeducation. And really, psychoeducation is talking with a patient to help them understand their problem, and includes the physiological elements, the sense of sexual self, the sense of self, the relationship difficulties that they have, the effects on life in general, and the interplay of all these elements that actually go to form our body image issues. Management also includes some general option, which is useful in all cases. So we work with mindfulness and relaxation. With some patients, mindfulness has already been a component of their cancer care, and they find this easier. If it hasn't been a component of their cancer care, then we will actually enable them to get some mindfulness help. Relaxation is important, and we look specifically at the use of abdominal breathing and paced breathing. Then we would look at the body image work, and we would look using the Phyllis Alden model on areas that have been identified by the patient. And then we will also look at specific options for the anatomy and physiology changes, which will help control and function elements. And some of these would be things like vulvar care, and there is a podcast on that, the use of dilators or vibrators, and the use of medications. I also want to look at something called performance anxiety, because I think that when we have had sexual problems and difficulties, or problems in our social life, or relationship problems, perhaps job problems and worries, all these things have a component of anxiety. We expect from our life story, our life narrative, which is what we call it, our understanding of the sense of who we are, the sense of self, we expect in our life ahead to be able to function in the same way. And having had a cancer journey, what we find is that these things don't necessarily work in the same way. And that gives us a lot of anxiety, and we call that performance anxiety. So what we find is that we have an initial failure for whatever reason. It might be in the job place, it might be in a social setting, it might be going dancing, it could be anything, it could be sexual. And because we've had that failure, we develop doubts and worries. And then what happens is that we start spectatoring. So when we go to the dance floor again, We start worrying before we go, and we stand out of ourselves. We don't enjoy the doing of it. We actually stand out as if we were looking in on ourselves and saying, well, it's not going to work. I'm not going to be able to do that. I can't get my leg to do that anymore. And as soon as we start worrying and spectatoring, standing out of our bodies and not going with our bodies, we get a nerve imbalance, and we call this the autonomic nerve imbalance. And the nerves stop working and we get another failure. And once we've done that a few times, those failures build up, and eventually what happens is that we actually start to avoid. So no longer will we go dancing. And then after a little while, if that's in the sexual side of things, we'll start developing relationship problems. I want to tell you about this model of sexual responding, because one of the problems that many patients who've had a cancer journey have is that of sexual difficulties, relationship, lack of communication and understanding, and they find themselves in a very sort of dark place often when they have a loss of intimacy. And I think it's important to understand that there is plenty of help out there for patients who do have sexual difficulties following their cancer journey. This model looks at the way we sexually respond, and we're doing it from a position of what we would call is sexual neutrality. The person who devised this model, called Rosemary Basson, said that everybody entered this model because they wanted some form of emotional intimacy. But I think people enter this cycle of responding for all sorts of reasons, especially if they've had a cancer journey. In this model, what we're doing is we're putting ourselves in a position of being receptive to sexual stimuli, whether we're thinking sexually or not, and using focusing exercises like mindfulness to stay in the moment of that, rather than to be saying to ourselves, nothing's happening, nothing's going to happen, I'm fed up with this, I need to get out of this situation. That nothing's happening is actually about how we process it in the head, and we call it is processed in the limbic system, which is part of the brain. And biological and psychological factors can influence how we act. If we are saying those very negative things about our body and how our body's working because of body image changes around control and function, we will exit at that point. We will not go further. If, however, we can be positive and stay with the sexual stimuli and explore that, then we may find that we get some sexual arousal. This may not be the same arousal as we had before, but if we can stay focused, staying in the moment, as in mindfulness, and stay focused on the sexual pleasure or arousal feelings that we're getting, arousal increases and then desire for more can kick in. Satisfaction, of course, can be physical, so we might find we do get an orgasm. So people with vulval cancer can find that they get an orgasm which they were totally unexpecting. But it can also be emotional satisfaction, so that we feel closer to our partners, even if we haven't had a physical outcome. And that actually drives this process of sexual responding. I'm going to stop there, and it may be that you would like a further session on some of the models of sexual responding and some more work on the sorts of treatments that we offer. It might be that you would like something around mindfulness, or it might be that you would be happy to be looking at something very much more specifically sexual. We have done a podcast on vulval care, so if you haven't seen that one, it will be useful to see that one. I hope you've enjoyed this. Stella is with you to actually answer any questions, and I just thank you for listening, and I look forward to more comments. Stella will pass on various questions if she can't answer them herself. Do it without